Okay. First of all, I would like to thank Professor Dr. Amal Bishlawi and Professor Dr. Mervat Matar, Professor Dr. Azza for inviting me to be here, to be a chairperson in this session. And it's my pleasure to introduce to you. Okay, please, Dr.
We thank Dr. Adel Abdurrahim, Dr. Amal Zidan for being our chairpersons in this hopefully very interesting session. And I thank Dr. Hala Farawela, head of the Clinical Pathology Department, Cairo University, my dear friend and colleague. She's going to introduce us to the art of diagnosis of chronic lymphocytic leukemia. For Dr. Hala.
Thank you, Professor Mervat, for your nice introduction, and thank you all for inviting me for the start of, it's a simple lecture of the art of the diagnosis of the CLL. Actually, the challenge in the diagnosis based on that CLL either to be an indolent course, so it stands no treatments, that's to say it's a slow-go disease, or an aggressive disease which require aggressive treatment. First of all, the genetic basis plays a role which is actually constituted near than 80% of cases. And we have some sort of a genetic predisposition, and that's why it runs in families. We have an initiating lesions that it's actually deletion of the 13q, which harboring the microRNA 15 and 16A, which is actually leading to aggravation of anti-apoptotic effect and expression of the BCL2. So actually the clone, if we have a starting clone, it persists and it never dies. With a further activation of the B-cell receptor antigen, which act as a promoting factor, so actually the growth of the CLL clone persists. Further markers added with more molecular and genetic changes that will aggravate and amplify the clone, as well as the microenvironmental action, which is adding as a factor for the progress of the disease. What we mean that we want to diagnose actually the patient. We want to diagnose the stage of the patient. We want to anticipate the time for proper treatment, the time for first treatment. Also, we want to detect the complication, genetic mutation, and clinical progression of the disease. Can we anticipate the disease progress? And lately, hopefully, we have a better outcome of treatment and patient survival. The prognosis or the diagnosis is based mainly on the peripheral blood data as well as additional tool. Let's be very concise. The NCC guidelines 2019 stated that actually we should have the blood as flow cytometry is the main diagnostic tool. Biopsy is generally not indicated. So actually we should do flow on the peripheral blood lymphocytes. If we have a biopsy from any tissue, especially the bone marrow or the nodes, it should be revised, and we should have the affected area revised and examined properly. If we don't have a lymph node pathology, fine needle aspirate is not an ideal state. However, if we have it, we should add further tools like the immunohistochemistry and flow cytometry. And of course, we may have a monoclonal B lymphocytosis. So the CLL is actually, it's a very homogeneous morphology, but it's a very heterogeneous genetic background with actually the persistence of the monoclonal B lymphocytosis in the peripheral blood more than 5,000. And we should prove with the flow, which is the first diagnostic tool, is clonality, it's a kappa or lambda restricted. And we should have the adequate phenotype that it proves it's actually a CLL clone or not. What's added in the 2019 CNN guideline, we should do with each flow, as well as cytospan analysis, to have a cyclin D immunohistochemistry, or to have a FISH analysis to have 1114 translocation, to differentiate CLL clone from any cases of mantle cell lymphoma, as well as the addition of CD200. As we just said that CLL is actually a blood disease. We have a monoclonal B lymphocytosis in the peripheral blood more than 5,000. SLL is the same synonyms, but actually it's in the lymph node and the spleen. And we have a peripheral blood lymphocytosis, it's less than 5,000 per cubic millimeter blood. CLL should be confirmed with the histopathology of the node, and your blood, it should be less than 5,000. Our tool, actually, the flow, we should have clonality, we should have proper markers, which is actually, we just mentioned, 19 positive, which is the pan-B marker, expressing aberrant 5, which is a T markers expressed on the same clone with a 23 expression, and 20 marker CD20, which is DIM, as well as surface immunoglobulin, it's usually DIM. 33 plus or minus, 10 negative. It should be done in the first panel. This is the CNN guideline now. It wasn't like that before. And we should do cyclin D1 on the cytospan analysis of the flow of the lymphoid population. Some cases, of course, they express 23 negative or DIM, and 20 may be bright, and surface immunoglobulin may be bright, which give a false impression that we should differentiate it from the mantle cell. So we should do also 11-13, as we just mentioned, cyclin D1 with immune histochemistry, and lymphocyte enhancer binding factor with immune histochemistry. So this is the value of the cytospan analysis that it should be added. This is, of course, the original or the classical typical phenotypic CLL clone, which is actually cells expressing pan-B marker, as well as an aberrant 5 and 23 with a couple under restriction. The old Mrd scoring is actually there. Some centers still working with it. You have a CLL clone with a 3 to 5 score, which is differentiating it from the B non-Hodgkin lymphomas, which ranging their scores from 0 to 2. It's a variations of expression of antigens with the surface immunoglobulin, whether it's weak or bright, or CD5, 23, and FMC7 and 79B. Not all the centers now is working with the Mrd scoring. However, we are still working with it. Whenever you have any cases ranging then scored 3 or less, you should go deeper and differentiate it from other B non-Hodgkin lymphomas. That we just mentioned that CLL and SLL is synonyms of each other. We have a blood disorder that we diagnose it with the flow, and then we have the lymph node and the spleen. The diagnosis of the SLL, it should be established with the flow. We should have a lymph node biopsy. We can take it as well. Aspirate biopsy is not enough alone unless you have a very good infiltration. Fine needle is not diagnostic unless it's combined with the immunohistochemistry and flow cytometry. This is the panel accepted for the immune stain for the lymph node, actually a pan-T marker, as well as 5, which is usually expressing on the same B clone, 20, and 10 to rule out follicular lymphoma, 23 to prove that it's the same clone of the CLL, and cyclin D1 to rule out mantle cell, as well as lymphocyte LF1, which is there in the CLL and not in the mantle cell. And this is the NCC guideline. They do the peripheral blood, followed by the phenotyping, and then immunophenotyping and immunohistochemistry to be diagnosed. We want to say that the bone marrow now, they stated that it's not needed for the primary diagnosis, and it's not needed before treatment, of course. This is the new guideline or new modification. It's no longer required for the initiation of therapy, but it's actually kept an informative diagnosis of the cytopenias which is happening to the patients. So bilateral aspect is enough, and biopsy. Type of infiltration, of course, we have the previous history that we never have a diffuse infiltration. This is mean an aggressiveness of the clone. It's not put now as an aggressiveness as it was before. Staging, actually the staging of the CLL clone is based on the tumor burden and the hematopoietic impairment, and this is give us the stage, and this I think will be discussed with Dr. Mrd, which is the right classification of Beignet, which is actually the lymphocytosis as well as the status of the splenomegaly with anemia or thrombocytopenia. In the Beignet, we have actually the hematopoietic values with the lymph node distribution, one area or two areas. When to anticipate to start to treat patient with a CLL, whenever we have signs of a bone marrow failure, we have aggressive splenomegaly. Before that, we cannot start the therapy. Before a lymph node examination and enlargement excessively, unexpected, and the persistent lymphocytosis more than 50% within 2 months, and lymphocyte doubling time actually less than 6 months doubled, and actually constitutional symptoms, weight loss and fever, provided that you don't have any cause of this fever and weight loss, so you should start at that moment the treatment. However, we should mention that it's applied now in the 2019 that absolute lymphocytic count alone and symptoms related to lymphocytosis cannot be an indication to start therapy. And leukostasis is rarely seen in cases of CLL, not like other leukemias. We should diagnose the complications. Actually, our complications is ranging from immune disorders, a viral affection, which is the patient usually immune compromised, so we may have a pure red cell aplasia when the patient is having parvovirus B19, herpes virus, as well as EBV, and of course the histological progression, which is very, very aggressive. Histological progression, actually, it's a diagnosis of a lymph node. So we should have a lymph node biopsy to diagnose progression and histological transformation. We should have a lymph node biopsy. If we don't have any lymph node biopsy, we can find needle aspirate is not enough. We can take a core needle biopsy from the high SUV lymph node, and we should combine it with other markers like the flow and immunohistochemistry to prove the diagnosis. Of course, to diagnose histological transformation, aspirate and biopsy is not enough, because usually the disease starts in the peripheral blood, in the bone, in the lymph nodes, and usually the peripheral blood is having cytopenia, and the marrow actually is not at that indicating the aggressiveness of the clone. Progression, actually, we have either rectal transformation, which could be either DLBL or a classical Hodgkin disease, and of course we should be very cautious to differentiate it. If we have a background of a CLL clone, we should look for the EBV infection, because EBV infection in the background of the CLL, this is not a diagnosis of a classical Hodgkin disease, we should rule it out. And the CLL turning into PLL expressing prolymphocytes in the peripheral blood more than 10 and less than 55. The diagnosis is mandatory. We should do immunohistochemistry as well as IGH sequencing to have the two clones. We have the original CLL clone as well as the abnormal clone. They have the same clonality or not. It's the same clone. Or if they have a different clonality, that means that it's another clone developing. We should diagnose actually the prognosis and staging of the CLL. It's based mainly on the deletion mutation of the P53, unmutated IGH, and beta-2 microglobulin value, as well as clinical data and age of the patient. This is the Ipi Scoring. It's divided into low and intermediate and high and very high. And we have a favorable and unfavorable according to the DNA sequencing. P53 mutations, the wild type is a favorable, unmutated is unfavorable. IGH is actually whenever you have a mutation less than 2%, it's actually unfavorable. We have a surrogate markers, which is the 38 and 7 and 49D, as well as we have the FISH study with a favorable prognosis, actually deletion 13Q. This is a sole abnormality, a bad prognosis, which is deletion 17 and 11Q, and the neutral prognosis, actually normal karyotype and trisomy 12. IGH mutation status is very important, and this is actually the new trend in the modalities, especially with the introduction of the chemoimmune therapy that it's now running in the CLL. We should screen all patients before treatment in the IGH mutation because it makes a great difference. Expression of the VH321 mutations is of great bad prognostic value. It can be detected by molecular PCR or sequencing study. Surrogate markers 38 as well as 70 and 49D. 38 more than 30 and 49D more than 30 is a bad prognosis. ZAP 70 more than 20 is a bad prognosis. However, the NCC guidelines stated that IGH mutations is the preferred method because 3849D and ZAP should occur only in the context of the clinical trial because the procedures, it needs to be standardized and it needs high reproducibility. IGH mutation is very important because, as we all know, we have two clones. Actually, the unmutated, which is more aggressive, it arises in the pre-germinal centers, expressing 5 and 27, and giving the bad prognosis or the proliferating clone, and the post-germinal, which is actually 5 and 27, giving the mutated form, which is actually usually quiescent, and it goes clinically in the slow-going strain without minimal complication. This is the unmutated, which is a bad prognosis, and the mutated, which is actually good prognosis. Of course, we know that this is the mutation study, which is we should do all the cytogenetic abnormality. Interface phase is very important to swear that we have 13q, which is the RB abnormalities, or trisomy 12, or 11q, which is the bad prognosis. We have an ATM expression of the oncogene, and deletion P53, or deletion P, actually with the P53 deletion mutation. We add to this is the molecular study, the S3FB1 mutation, NOTCH1 mutation, which is now rising. Deletion mutation P53 is very important. As we all know, we have 70% of the cases, they have mutation and deletion. We have just 20% mutation only and 10% deletion only. So we should now, missing in most of the labs, that we should do routine, especially in the complicated cases, mutation and deletion. Molecular study actually with the NGS is not that rising like the others we just mentioned, the ATM and SF3B1 and NOTCH1. It's not proved 100% now to be running in the classification of a prognosis, but we should look for them. What's rising very, very important that if we never add a stimulated karyotype, cytosine phosphate guanosine stimulated clone of the BCLL, of the CLL clone, which is usually tends to be non-dividing. If we add the stimulant, we can have a metaphase, and the metaphase with the 3 abnormalities, 3 independent chromosomal abnormalities in more than one cell is a very, very bad prognosis, even in the absence of unmutated and even in the absence of 17p. This is the worst prognosis which is there. If we collect all the prognostic factors, we have a clinical stage and complications, Benier stage 3C and Y 3 and 4, as well as we have all the signs of the autoimmune anemias and the thrombocytopenias, recurrent infections or transformation. Serum biomarkers which can be used as a prognostic value. Beta-2 microglobulin now is very rising to be used as serum markers for a bad prognosis, as well as increased LDH and increased thymidine level in the blood. Flow cytometry analysis as a surrogate, increased 38 more than 30, and ZAP and 49D. However, the recommendation now stated that it should be combined with the sequencing. FISH and karyotyping complex is the bad prognostic marker. We add 17p and 11q, one of the baddest prognostic marker as well. Mutational study, unmutated IGH, this is the bad prognosis. P53 mutation, it should be added as a mutation study regularly. Sequencing of the P53 as well as IGHV mutations. Now we have the prognosis. What's the value of that? We want to know the response of the patients. The patient enter into CR with the MRD positive or MRD negative, or PR with MRD positive and negative. Of course, the definition of the complete remission or the MRD clone that you have less leukemic cells. Preferred blood lymphocytes less than 4,000 and bone marrow less than 30 with a clinical aid. Now the birth of the MRD assessment in the CLL stated with the era of the immune chemotherapy. And here we have even MRD CR is better, of course, than the MRD negative CR is better than the MRD positive CR with a very good progression-free survival of the patient. When we compare the patient concerning the MRD positivity and even MRD positive negative CR, MRD negative PR, which is that you still have a residual leukemic cells, is better than the MRD positive CR. This is as regards the progression-free survival. We have here the MRD negative, negative PR. That's to say it's an MRD negative. It's much more better than the MRD actually negative CR in the prognosis. And this has actually helped in the lab with the introduction of the MRD study in the CLL clone, either with the flow or the oligonucleotide PCR or high resolution sequencing. Modification with 8 markers tubes that give a resolution of 10 to the power minus 5 leukemic cells. It's there. Of course, the all monoclonal antibodies clear the CLL clone from the blood, so it should be tested in the blood and the bone marrow sequentially. With the more advanced in treatment and integrated all together, it's anticipated that the combined target and non-target, which is either targeting the B-cell receptor or targeting the apoptosis, this will lead to the deep molecular and longing remission of the patient. And hopefully we reach a good when we have a good diagnosis, good prognosis, prediction, and we can have a good treatment strategy, so help to reach better treatment algorithm and detect early progression and relapse and hopefully cure. Thank you.
Thank you very much, Dr. Farawela.